Hello, and welcome to our webinar session with Laurel Gillespie from the Canadian Hospice Palliative Care Association. She is going to give us today a national overall overview of what is hospice and palliative care across Canada. And I want to introduce her, and she is the Chief Executive Officer of the Canadian Hospice Palliative Care Association. She previously held the position of Director of Advanced Care Planning at the same association, and she has a post-baccalaureate diploma in business management and a master's degree in business administration. She's a certified healthcare executive through the Canadian College of Health Leaders. Laurel has been on the board of Autism Canada for the past 7 years. She has numerous years of experience at the Ottawa Hospital Cancer Centre and at the House of Commons supporting members of Parliament. She has been nominated for consideration as a senator in the Canadian Parliament for her good works. Thank you very much, Laurel, and welcome to presenting this session with us.
Thank you very much, Sharon, for the opportunity to join you folks today as you're well underway in your global cardiopulmonary fibrosis awareness month. So it's a pleasure to be here with you today. A couple of little housekeeping things for me before I begin my PowerPoint presentation is that I would like to respectfully acknowledge that I live and work and play on the Algonquin, the unceded Algonquin territory and the Anishinaabe people. And yeah, so it's great to be here. I'm going to share my screen now and hopefully this will work just fine. We all know sometimes it can be a little bit challenging at times. So I'm here today to present to you sort of just a higher level overview on the national perspective on the state of hospice palliative care in Canada. And I'm just going to move to my next slide if it's going to work for me. I don't have any disclosures today. There's no conflict of interest on behalf of CHPCA or myself before we begin. So what is palliative care or a palliative approach to care? So it's a specialized form of healthcare that we provide in this country, the best that we can for individuals and families who are living with life-limiting illness, and usually at an advanced stage. And the goal of palliative care is to enhance quality of life while you're living and to provide comfort and dignity for the persons living with an illness, as well as the best quality of life for both this person and their family and loved ones. So it's really about a very holistic approach to ensuring that people's needs and various differences and beliefs are respected and carried out for them to reduce suffering. So it includes, as I mentioned, it's a holistic approach, and it's also an interdisciplinary approach to care. But primarily what we're trying to do is provide some pain management. So the healthcare providers from PSWs and the nurses and the physicians work closely with the patients as part of their circle of care and their families to find out what may be causing them pain. Is it a sense of loss and they're grieving that they're no longer able to drive, as an example, or because sometimes it will little things that make us happy and bring us joy can manifest itself in different ways. Pain being one of them, when it can trigger. And so, what are some of the appropriate ways for the individual to help relieve the pain? So the symptom management piece can help relieve accompanying symptoms that may be causing distress through knowledge and an understanding of what's causing these manifestations, and then treatments that might be appropriate for the individual. A big important component of a palliative approach to care also includes social, psychological, emotional, and spiritual support for the individual and their family. So it's important to recognize that a person's physical and mental health, as well as their cultural or spiritual needs, are also being met. It also looks at the caregiver support, because what we do know is caregivers, those who are supporting individuals with life-limiting illnesses, often have needs that go unaddressed and need to be part of that holistic approach to care. So who is the Canadian Hospice Palliative Care Association? So I'm relatively new in this sector of the healthcare industry, if you will. I started at the end of January as the CEO, the first CEO, and I follow in the footsteps of Sharon Baxter, who was the executive director of the organization for 19 years. So I have some big shoes to fill, but we're coming up on our 30th anniversary of being in existence this November. So we're pretty excited about that. But just to share with you the perspective on our vision statement is that all Canadians have access to quality hospice palliative care, regardless of what your postal code is, or maybe even in some instances where you don't have a postal code. Our mission statement is really to be the national leader in the pursuit of quality hospice palliative care in Canada through public policy, education, knowledge translation, awareness, and collaboration. So our strategic plan, right now, we're just beginning the process of creating our strategizing for the next 3 to 5 years. But for right now, our key strategies are to lead in the advancement of hospice palliative care policy across Canada. A large part of that is to but to create some model of standardization across the country where one can expect to have a level of care that's synonymous with quality palliative care. And we've been working with the federal government. I'll get into it a little bit later in the presentation, but we do have a palliative care framework that the government passed in 2017, and tied to that is also an action plan. And out of that will be a national strategy in addressing hospice palliative care in Canada. So another part of our key strategies is to promote awareness and learning in quality hospice palliative care for diverse audiences across all sectors. Also at the same time being respectful of the various jurisdictional differences and laws that we have in how our healthcare is delivered in Canada with respect to the different provinces and territories and the autonomy that we have and how we deliver to the area that we reside. We also hope to increase our capacity to achieve our goals and meet the needs of the association's members and the public. So our members are not necessarily individual members of the public, but our governance structure for the organization is such that our members are actually the various provincial territorial associations across the country. So why do we need hospice palliative care in Canada? And I'm going to say, first and foremost, as part of, I'm a trustee with the World Hospice Palliative Care Association, and fundamentally, that organization, as well as myself, believes that access to quality palliative care is fundamentally a human right, that we all deserve to die with dignity and having our most basic needs met, including reducing or mitigating suffering and pain. And we have a lot to be thankful for in Canada with respect to our level and quality of healthcare. However, there's a lot of work that needs to be done in the disparities and the fragmentation of how palliative care is delivered and how it's funded, and assessing it. So there are some inequities. So we do know that people are beginning to demand or to ask or request more palliative care as they approach end of life. But that between 62 and 89% of those who die, they really could benefit from a palliative approach to care. And often what we find is that it's being offered too late or not at the right stage, at the right time, and in the right circumstance. So including nearly everyone who does not die unexpectedly is where those numbers come from. 85% of Canadian public support the integration of national standards and palliative care health services into the Canada Health Act. As and this is coming back to that as a fundamental human right, we should be able to access quality palliative approach to care. So there is a lack of access. As I said, there's also the funding model and how hospices are funded. It's different from every province and territory, but there is a significant issue around a lack of access to appropriate palliative care services at the right time. So only 15% of those with serious illness or life-limiting illness have early access to palliative care in the community. And I think this is really important because we often look at palliative care being synonymous with end of life. And really, fundamentally, a palliative approach to care is really about how well would you like to live until your last breath. it begins, sometimes a palliative situation can go on for many years. But it's about having really uncomfortable discussions sometimes, but necessary, essential conversations about what one's wishes are as their life-limiting illness or their serious illness develops and manifests as through the trajectory of the prognosis. So whatever it is, the ailment that they are suffering from. So I think that's really important to understand that it's not just about end of life care, and it's really a much broader approach to ensuring that a person's needs are being met. And, from the time of the onset of disease right to the end, and including afterwards, because patients, their families, the families of loved ones of the patients who are passing away are also going to benefit from grief and bereavement supports after end of life. So 80% of the time when palliative care was provided in hospital during admission, the stay was unplanned, or the person actually entered into the hospital setting or clinical setting through an emergency department. So again, continuing on why it's important, receiving a palliative approach to care provides improved pain and symptom management and a sense of receiving emotional support. And that's a really important factor when you look at the circle of care and those who are involved in making the decisions on your behalf if you're not able to for yourself, et cetera. But having that additional emotional support by your healthcare team and loved ones being part of that is really important for people to feel like they really have a better sense of being cared for. And that's really what we want to try to impart as well, is we want to respectfully be as compassionate as we can and empathetic, but also at the same time ensuring that people's healthcare needs are met to the best of our ability. So with increased satisfaction of care for patients and loved ones, we know that people have a much different experience when a palliative approach to care is implemented and as early on as possible. So it reduces the need for emergent care. So receiving community-based palliative care earlier is associated with fewer visits to the emergency department. It provides a clearer sense of what one can expect during the prognosis of their illness and what they can do while the patient is at home to manage pain and so on and so forth. So the intensive care unit stays in the last 30 days of life. It reduces the need for people to go into that higher level care often. So 65% of palliative care patients' family members reported that their emotional or spiritual needs were met, compared to 35% of usual care patients' family members would have received. So most Canadians, we know from various surveys that were done, the last one being with the Canadian Institute of Health Informatics that we did in 2018 in partnership with them. We're just at the beginning processes of starting the questionnaires of what that next survey will look like. So if anybody has specific things to pulmonary fibrosis that they think should be included in there, I'd love to hear from you. So hospice palliative care and lung disease. People with lung disease often face as much pain and other mental health issues as cancer patients. These are, we have so much information and knowledge about how we can do a better job at helping to treat and mitigate through symptom management. It's really disheartening to see that we don't and can't do a better job at this, because I believe it's possible. So patients with lung disease often face a sudden worsening of symptoms like shortness of breath or a sudden end of life event. So hospice palliative care can prepare the person experiencing the symptoms and their caregivers in case these events do occur. So again, it comes back to that, what can one expect in terms of their prognoses in a palliative approach to care, and reduce the likelihood that they would have to go to visit an ICU unit or at least the emergency room upon entry. So advanced care planning, though, is an interesting piece that's really starting to pick up a lot of attention, and it has for a few years now, but it's sort of becoming more common practice. So advanced care planning provides an action plan, if you can liken it to that, about what you would like to have happen in the event that you're not able to speak for yourself or have your needs communicated. So we know that by participating in advanced care planning, so that the whole team, your circle of care, knows what your expectations are, what your limitations, and agreeing to what you would want to have happen to you. It actually reduces stress and anxiety during these times where there is a sudden change in one's condition. So it's really important. And I have a dream that one day I'd like to see a QR code on our health cards or driver's license one day. And that is actually doable because it would respect the provincial jurisdictional issues around the legislative and differences in laws across the country. In this reference, people in the UK with lung disease shared that in the last year of life, what was most important to them is having a realistic understanding of their expected symptoms and quality of life and their disease progression. So again, it comes back down to that quality of communication and an understanding, a shared understanding of what an individual and their family and loved ones may expect during the progression of their illness. I feel like I'm talking really fast, so if there's any questions or anything, do let me know. So with hospice palliative care and idiopathic pulmonary fibrosis, symptom management is essential in hospice palliative care for people with IPF. So people with advanced IPF face a heavy symptom burden and a poor quality of life. And hopefully we can work together and collaborate so that we can have better understanding through community of practice and community of practices and sharing what works really well in certain areas to help reduce and mitigate that symptom management. Shortness of breath is a common symptom among people with IPF, and hospice palliative care offers several symptom management options to minimize its impact on quality of life. So shortness of breath has a strong negative association with quality of life and prognosis, because it's largely probably, or is likely due to the fact that anything the individual is going to try to do to maintain their quality of life and things that bring them joy, they may have to alter or not be able to participate in. So it's hard. I think it's a challenge for individuals with IPF to actually, be able to impart that sense of having some control when they're having difficulty and not having the energy or wherewithal to be able to participate in their normal activities. And as one experiences having the things that bring them joy and bring them peace and happiness and just joy in general, and then those things are starting to be taken away from them, it can be particularly distressing and burdensome for them as they go through their disease prognosis and trajectory. So several studies on hospice palliative care offered to people with IPF indicate that there's a greater need for early integrative palliative care with the complementary sideline of advanced care plans to improve overall life, end of life care received. So again, it's finding these tools that will help ameliorate any of the uncertainty around what one could and should expect with their prognoses. So CHPCA has a really interesting role in the landscape of quality end of life care in that we act as a secretariat or the secretariat for the Quality End of Life Coalition of Canada, and that's a mouthful. What is the QELCCC? So QELCCC currently is a group of 35 national organizations that are dedicated, and our sole purpose is to promote quality end of life care for all Canadians. So you can read the mission statement, but we do believe that we have a right to quality end of life care that allows a person to die with dignity, free of pain, surrounded by their loved ones in a setting of their choice. Because not everybody wants to die in a hospital. Not everybody wants to be in a hospice. Many people want to be at home, but it's what's important to the individual that needs to be respected. The coalition believes that to achieve quality end-of-life care, Canadians, there must be a well-funded, sustainable national strategy for hospice palliative care, or hospice palliative and end-of-life care. And it's the mission of the QELCCC to work together in partnership to achieve this goal. So it's interesting with QELCCC in this year in particular, since I've become CEO of the organization, is to really amplify the voice of the QELCCC as a collective group of delegates who all share this commonality, respectful of the organizations that they're representing. So Heart and Stroke, I mean, there's a whole listing on our website that you can go to see exactly who belongs to it. But my point in that was that there are organizations such as the Canadian Cancer Society. So although their mission is not, it's not about just end-of-life care, we have organizations such as the Canadian Society for Palliative Care Physicians, there's pallium.ca, there's Canadian Virtual Hospice, and ourselves, that are really the four leads in palliative care as a national organizations that our sole existence and mandate is to deal with just end-of-life care. So we've been doing some great work, and in trying to amplify that voice, we're trying to really ramp up our website so that people can have rapid access to a repository of the right information at the right time, specific maybe perhaps even to their illness or disease. So it's really a great partnership that we have with these organizations. And they're played a very important role in the palliative care framework and competencies as an example, and trying to achieve quality end-of-life care for all Canadians.
Excuse me, Laura.
Yes.
A question. Someone wanted to know, can you give the distinction, the difference or similarity between this, the Quality End-of-Life Care Coalition of Canada, and what they're trying to achieve at the Medical Assistance in Dying? I mean, they also believe in dying in dignity and choosing when you would like to die. And it seemed very similar to yours in this coalition. So could you maybe, give us a distinction of the differences or maybe similarities?
The number one distinction between, what we're trying to do with providing quality end-of-life care and MAID is we don't necessarily promote anything that hastens death. Death is a natural part of living. It's how, we come into this world, we leave this world. So anything that we promote doesn't hasten the dying process. And it's our belief as a collective that quality end-of-life care, when a palliative approach to care is offered and offered early on, that's what's most optimal. That there are very few circumstances where symptom and pain management cannot be managed. But I certainly do appreciate that, I would never propose to say that, MAID is good or bad, and that MAID is, shouldn't be offered, should be offered. It's here, it's occupying space within our healthcare system. It's my belief that it doesn't necessarily need to occupy space within a hospice and a place that the intention is to honor that the natural process of death and dying, but in a respectful and such a way that the individual does not suffer. So it's not up to us to decide, who should or shouldn't receive MAID or whether it's good or bad. Our job is to promote the fact that a lot of times, in fact, I believe it was 30% was the latest statistic, that of all Canadians that died did not have access to palliative care. 30%. And to me, that's not good enough. There's no reason why every individual in this country, through technology, telemedicine, virtual visits, we've got, cameras on our phones that can take a good picture of a mole that may be, not doing so well, that we can share information rapidly. And there's no reason why we shouldn't be able to deliver palliative care across the country. And so I suffice to say, I hope that answers the question. Is we don't promote it one way or the other. but the difference being that the palliative care doesn't do anything to hasten the dying process in its simplest form.
Okay, so if that's the case, if somebody was, part of the palliative care and they're being taken care of, but then, and towards the end, they thought, I'd like to explore the medical assistance in dying, will palliative care help them through that exploration to decide if they stay with palliative care or if they maybe move over to the medical assistance in dying, which is MAID?
Yeah, that's a really great point. And a lot of people maybe don't understand that is, it is an option that's out there. And I speak to this as, and I will be a bit candid about my own experience. So I am a cancer survivor. Knock on wood, it's been 14 years. And I've self-reflected on what it would mean to me if I were suddenly or expectedly found myself receiving palliative care and said, oh, you know what, I've had enough. I want to stop the treatment, and what else might be to my avail. I think quite commonly, particularly the women, we don't want to be a burden. We don't want to cause any undue distress. And MAID can be and has been an option in hospices across the country. Don't know that there's any hospice that has blatantly refused to carry out MAID, other than the situation that we saw in the last couple of years in Delta, BC. The argument there, though, and it gets quite complicated in how hospices are funded. A lot of them are funded mostly due to bake sales and community fundraising and little bit from the government. So it really depends on the structure of how that hospice is funded, what they can and cannot do or decide for themselves, and how they're going to be. So some hospices may be mandated because a certain percentage of their operating budgets come from the government to, you will do X, Y, Z. So I can tell you that patients have been in palliative care in a hospice setting in this country, and they and either the individual and their substitute decision makers, whomever on their team and circle of care, have decided that maybe that's the best option for them. And they're not denied that, so that a team can come in and deliver MAID. That's probably the most common scenario. That way it doesn't cause moral distress on the individuals working within the hospice either. And it prevents the patient from actually having to be moved to a unit at the hospital. So again, it really comes back to a palliative approach to care respects and honors the person's wishes and what they value. So, and what's in their best interest. So if they're asking for it, MAID is here, it's here to stay, it's occupying space. But we're at kind of that pivotal point. It's still relatively new since the most recent changes have been made in assessing it. So it'll be more telling to see, who's requesting it. So I think those latest statistics that I had shared that they're from 2018 with the 30% of Canadians that have died. There was like 230,000 or 235,000, something like that. 30% of them passed away and did not have access to palliative care. It was something around, and I might have it later in my slides, I'm not sure, but I believe it was 1.6% of all those deaths were MAID requests. We have actually experienced a really interesting phenomenon when people who've been in palliative care or begin to receive a palliative approach to care, and their symptoms are managed, their needs are being met emotionally, spiritually, their circle of care is being comforted and feel that they're being cared for, that people have chosen to elect MAID as part of their course of action. And once they've gotten the things that they need to have their basic needs met as they deal with their disease at end of life, that they've changed their mind and said, actually, now that my pain and my suffering is being managed collectively on a mental, spiritual, all these different levels, because it's a holistic approach, they change their mind. So that to me is very telling that, once things can be brought under control, and as I mentioned, and I don't have a medical background, I have many years that I've worked in the health sector. But I'm not a clinician, I'm not a nurse, I don't have a medical background. But suffice to say that when a person's feeling better and their pain is managed, they've elected not to choose MAID. And there's very few situations where pain and suffering cannot be managed. And there are interventions that can be carried out to induce a coma phase for people, so that they're. But again, from what I've learned from my colleagues in this area, is that it's very few and far between the case that pain and symptom management cannot be managed to the point where the person starts to feel better and feels that they have some control.
Okay, thank you.
You're welcome. So again, I'm just to recap on that last piece, is it needs to be well funded in order to be sustainable, and that national strategy for hospice palliative care is going to be important. So the federal election priorities for this year is to fully fund and implement the framework on palliative care in Canada. And part of that framework is to establish a centralized national coordination office, so that there is some consistency in how palliative care is delivered across the country. It would also earmark funding for a Canadian palliative care implementation collaborative to ensure that, you know, the people who need to be around the table making decisions about palliative care have a seat at the table. And that's been very important to us as part of QELCCC, but as a national organization, to ensure that no one gets left behind. And if one thing's become very, very clear to us, is that COVID hasn't really shed a light on it. It's just amplified the lack of access to palliative care across the country, and those who are further have issues and challenges around assessing it. So our ask in our budget submissions and our federal election priorities also included 8.75 million of new funding over 3 years, specifically earmarked for palliative and end-of-life care on research and knowledge translation. So this is, again, you know, and I'm the audience that are participating today are likely acutely aware of the lack of research funding and how it's divvied up in Canada. And this is an area where it's still relatively new, but is still part of an overall healthcare system or approach that, you know, we've done really, really well in medical technologies and medical advancements, and, you know, having really great equipment to work with, and in a universally publicly funded setting. But we don't do such a great job when it comes to end-of-life care, particularly around research and sharing knowledge translation from that research, because there's a lot of wonderful, good stuff that's coming out around compassion, around, you know, just a lot of things that have to do with palliative end-of-life care. But that things that we haven't thought of before that people are starting to share that really makes a big difference in the experience of losing someone at end of life. So federal funding for hospice palliative care, the home and community care, the government is engaging provinces across Canada with investments of 11 billion over a 10-year time frame. And this was something that was part of the budgets that were passed in 2017. So the two priority areas are home and community care and mental health and addiction. And the home and community care piece is that we have found that most people would prefer to die in the setting of their choice, and it's more often than not in a hospital or clinical setting. That people are aware that there are other options. It's just assessing them. So that's a bit of a breakdown. 900 million for the fiscal year beginning on April 1st. Haven't really seen a whole lot of that coming down the pipes. And again, because of, you know, today's election day, anything that was in the trudges or in the works of being approved is sort of stalled. And we don't know exactly what the future is going to hold for us, but I'm very hopeful that we'll see some appropriate funding be designated toward palliative approach to care and end of life care. So we also were calling, we actually sent letters out asking all of the party leaders for their support in our 3 asks for the sustainability of what we are offering, and then the research and knowledge translation, et cetera, as mentioned. But we also want to embed palliative care in a national and in national long-term care standards. So acknowledge the importance of early integrative palliative rather than misinterpreting palliative care as only end of life or last days. And to ensure that there's consistent education standards and training that are implemented widely and broadly and purposefully within long-term care settings. And then have standardized performance measures, because you can't effectively understand how well you're doing at something if you don't have anything to measure it against. And again, one doesn't have to even mention COVID to understand the things that we've been privy to learning of what's happening in long-term care settings across the country. So recent passing was Bill C-220, which has now become law. I believe full implementation, the date is September 30th, which coincides now with our first National Day of Truth and Reconciliation. But Bill C-220 received royal assent on June 29th. It was a private member's bill by an MP, Matt Jenneru, who had personal experience with losing his grandmother and having to decide whether to go to visit grandma or take time off work. And it was in the early stages of a career. And, regretfully, he decided to, not go back to visit grandma, and understood only after her death that, wow, you don't get a do-over. And so he's really been a strong champion on Parliament Hill to extend the period of bereavement from the current 3 days to 10 days. They're not 10 paid days, but you're entitled to up to 5 additional days more off without fear of losing your job. It also expands eligibility for the leave to include employees who at the time a family member passes are on compassionate leave to help care for someone who's sick. So I know that with the responses that we received from the party leaders, as we did hear from the Liberals, the NDP and the Conservatives, that they were very supportive of what we're trying to accomplish when it comes to palliative care, and all have their platforms and details about that. But there's a few of them that we didn't hear from, which was a bit concerning. But election time is busy time, and funding is critical with the number of people that you can have answer emails. But it was nice to see that the parties, the 3 major parties, were at least it was on their agendas. So we have some future upcoming awareness days, and that's a big part of one of our core competencies as a national organization, is around the advocacy and awareness, and helping to educate people about what is palliative care and what isn't it. What can it do for you? So we have National Hospice Palliative Care Day for Children coming up October. It's actually October 8th. So I apologize that I didn't catch that typo there. It's actually October 8th, and we're going to be holding some webinars. October 9th is actually World Hospice Palliative Care Day. And the theme around that is leave no one behind. It's equitable access for all. And I can tell you, as disparaging as some of the things you hear about in Canada, sitting on the World Association as a trustee, it's really heart-wrenching with what some other countries experience when it comes to end-of-life care. But we can still do better. We have our upcoming biennial Canadian Hospice Palliative Care Conference. We have some great plenary speakers. We had to go virtual. We made that decision last February, thank goodness, because look at where we're at now. I wouldn't want to be bringing people together with what we are currently experiencing. So we're going virtual, but it's pretty jam-packed. It's not going to cross into your weekend. So I encourage you, if you're interested in learning more about palliative care or what the latest research is in this country, I highly recommend you check it out. We're just in the final process of our scheduling, but it's jam-packed and really interesting, and some great speakers who are going to be opening and closing. We have been offered some space to participate in a global Compassionate Communities Day program. It's not our day as an organization, but we've got some activities planned for November 1st, which is the first time that this has actually happened in Canada for a Communities Day. And then we have National Grief and Bereavement Day, November 16th. It's always the third Tuesday of November. And we're going to be doing a second version, so Saying Goodbye Concert version 2.0. We've just confirmed our final talent. We have representation of musicians from across the country, every province, every territory, good mix of French and English, but we're doing a hybrid event. We'll be hosting the fourth stage of the NAC, and we'll be having a few live performances from those who are able to make it, as well as interspersed with video performances from these artists across the country. So the purpose of the concert was to acknowledge and reflect that, you know, death has been disrupted by COVID, and the natural, you know, grief and bereavement and dying is a natural life experience, but we've not been able to experience those in a normal way due to restrictions and being able to have access to your loved ones. So it's a way of honoring and acknowledging the fact that we've all had to change our thinking and our approach to how we grieve in the early stages and how we bereave. So that should be a really interesting event. It is free. We want to do things so that we can try to make things as accessible for all as possible. But if you'd like to make a donation and have enjoyed enjoy the concert, if you so choose to participate, donations are always welcome. So we can continue to do things like this. We have National Caregivers Day, which is actually a day that was introduced by the Canadian Home Care Association, but through us in a partnership, we do the awareness for them on that day. And this past year, we did an exclusive screening of the movie The Father, where Anthony Hopkins plays the father who's been diagnosed with Alzheimer's. So we like to do these little events that try to bring light to the importance of things like caregiving, the importance of advanced care planning. We did a second screening of it on that day as well. And then we did a third screening of it during National Hospice Palliative Care Week. So something, again, it was a sort of a free event, but you could make a donation to give back so that we can have our own sustainability in affording to do these great things. And this is my slide for references, anywhere you had seen in the slide presentation. And you can find us at chp.ca. And before we go into any questions, if there are any, I wanted to share something that I think, regardless of your political stripes, we had a politician in this country that once said, we're all in this world together. And the only test of our character that matters is how we look after the least fortunate among us, how we look after each other, not necessarily how we take care of ourselves. That's what really matters. And that was Tommy Douglas, who really was a true champion of our universally publicly funded healthcare system. And, I think we all have a shared responsibility to ensure that we continue to have good access to quality healthcare and quality palliative care. And I do believe, and I hope you would share in that it is a fundamental human right to have a good death and a death with dignity. Thank you. And I welcome any questions anyone has.
Yeah. Thank you, Laurel. It was an excellent presentation. And, we have some folks who have some questions. So someone wanted to know who has the ability to refer, to make a referral for a patient to hospice. My understanding is that any one of your medical team, your healthcare team, can make the referral if you're fortunate enough to have a physical hospice in your community. But it would be you'd either want to speak with your specialist or your family physician. I don't know, there might be certain circumstances depending on the geographical area too, where someone like a nurse practitioner, or I would dare say that it wouldn't be a PSW, but maybe even one of the nurses or nurse practitioners that work as part of your interdisciplinary team
Because usually at that point, there is very much an interdisciplinary approach to that care. So it would be anybody on that medical team.
Okay. Laurel, you've done a great presentation on how to access palliative care and what it would do for the patient. What about for the family? Many of our families will express that, a lot of them are concerned about, at least the patients are saying they're concerned about their caregivers because they recognize the amount of stress mentally, physically on their loved ones who are looking after them. And quite often they're afraid to leave them alone to even go out for simple things like getting their hair done or maybe going grocery shopping. Can you tell us a little bit more about how palliative care can also help the individual's families, to manage that care as well?
For this one, Sharon, and if people will bear with me, I'm going to speak from lived experience. So even it was coincided with when I was going through my own journey with cancer. So, and I have to say, this was, 14-ish years ago. So I was care provider to my mother-in-law at the time, who had dementia, and she lived with us. And as a military wife, my twins were 9 when I was diagnosed with cancer. My youngest was 6. So 2 9-year-olds and a 6-year-old. I have cancer. I have no family in the Ottawa area. I have my elderly mother-in-law with multiple comorbidities and dementia living with us. Looking at, a 3-year minimum wait list to get her into care for long-term care at that time. And it was how are we going to manage through this with chemotherapy and radiation, and she couldn't be left alone. And I have to tell you, it was through the good graces of having community services, by means of having some PSW support come into my home. And I was very fortunate to I had 4 hours a day, Monday to Friday. They came in, they got her up, got her breakfast, got her lunch, took care of her basic needs, toileting, showering, that kind of thing, so that I could have my own self-care, my own time to go to my medical appointments, get my groceries done. And there were times when I had to access services out there in the community, such as short-term stays for respite. And if it weren't for those community level supports that were to my avail, I don't know that I would have been able to keep her for 6.5 years. And as it were, she was only not with us for 5 days before she passed away. So that 5 days, I'm pretty sure that it was far less expensive for having the PSW care come into the home to support the family, and then the access to these short stays whenever I had to have chemotherapy treatment. If it weren't for, and it would have cost a lot more to have had her in long-term care for 6.5 years than it was to support the family so that we could keep her home where she wanted to be, surrounded by her loved ones until the end. So from a personal experience, I can tell you that it makes all the difference, because I just went through this journey again. We just lost my second marriage. We just lost my mother-in-law this past July, and the hospice actually in Wakefield, Quebec, had to suspend admissions. I shouldn't say close their doors, because they never close their door. But due to nursing staffing shortages, they had to suspend their admissions. And my mother-in-law ended up passing away in the hospital, but it took months and months and months and months and months even to get a palliative assessment because of the shortages and supports. But the two experiences were very different from one another. And I can tell you from personal experience, when the right supports were put in place at the right time, I felt like we could have survived anything. And we did. We went through a difficult time, but at least I could leave to take care of my own needs and take care of the needs of my broader family, my little nucleus. And still provide care and a good environment for my loved one to have their last years at home. So I can tell you from personal experience, it makes a huge difference. And even after passing, the grief and bereavement supports that are made available to help people go through that process is part of that palliative approach to care.
Okay. Yeah, so I guess that the thing is, how do people access it? How do people know where to go get all those services? Is it through palliative care? Are you able to help people to access that care in each of the provinces to say this is what's available in your community? Because quite often, I know from my own personal experience, it's very hard to find all those services. You have no idea where to look for, how to get it, and it's always the matter of cost. If there's a cost involved, a lot of times, out of some really great charities, there isn't. But even to access them, I know from personal experience, it's difficult because they're stretched. So much, many people need that service. So is palliative care or, Hospice Care Canada, are you able to have that list on your website so people can go and look and try to find those resources and tell us how to access it?
The navigating of it's very complex, and sometimes I try to explain to having conversations is, people say, oh, how do I know how to find things? And it's such a challenge. And if I consider myself to be very fortunate in that I have a good education, and if I have a hard time navigating these systems, how does sort of the average person, or the person who's maybe just doesn't have that acuity to access things, or people to support them to know where to look? So one of the ideas that I had early days on with our website is to create sort of like a hub of information. So we have a map of Canada on our website that under our resources tab that you can hover over your province that you live in. Intuitively, we kind of just hover over like where we live because we want to see what, you can see it happening across the country as the map as your mouse moves over it. But it populates what resources are available in your province. So we're kind of because we don't have oodles and oodles of money to spend on things like this. It'd be really nice to actually have the development of not only when you hover over the map, you can actually have the cities and communities in which you live and what is available. The challenge that we face is putting so much information up there that we're not able to manage the content, that it's reliable, up to date, and the right information is getting to the right people at the right time. But there is definitely a need for this. And this is one of the things with having a national palliative care organized like office, if you will, is to be able to direct people, to be able to direct the provinces, and to be able to get that information out at the right time to people. It's challenging. And one of the other ways about helping families to be able to access it is through our education system. So, we now have paramedics who are out in the community providing palliative care, symptom management, for example, and administration of medication and whatnot. PSWs, we're just in the process of refreshing our modules around palliative care and for PSWs. And maybe one day, who knows, we'll get to like a national certification. So there's standardization of practice so that no one's left behind or left out, and that it's more easily, what is PSW? So personal support worker. Often, and it's kind of funny, they're sort of, not they're funny, but it's a challenge because often the PSWs are the personal support workers who are in the home, in the community, and act as that liaison between the broader medical team, are the ones who more intimately know the patients and families and can have that. So when there's consistency in that, it makes it a bit easier too. But it is a huge challenge, and I don't have or purport to have all of the answers to that, Sharon, but it's one that needs to be addressed for sure.
Thank you. One of the things that I know from having worked on the other side of the fence, we're trying to figure out how can we access all these cares and things. A lot of those individuals, even the personal, social worker, a lot of them are not well paid, and even the people who support palliative care are not well paid. And so there's a huge concern that, as the individuals, the good folks who are already in the system, as they age out and retire, who's going to step up to replace them? And I guess one of the questions to you is, what's the solution? How is your organization trying to ring that alarm bell to say, listen, if we don't look at this with the aging population from the baby boomers, how are we going to sustain that tidal need, because as I see Statistics Canada, every day 10,000 people turn age 65 every day in Canada, for the next 10 years. And so the concern is how we're going to deal with all these individual needs, as well as people who are in our pulmonary fibrosis community who have this rare disease. How are they going to access those needs too? You have so many competing needs, right?
Mhm. And it is very complex. We have the population of California, and we're dispersed over the second largest landmass on the planet. So the challenges in delivering adequate healthcare at the right time in the right places is really a great challenge. So what are we doing as an organization? We're doing everything that we can to help people understand that a palliative approach to care is one that is it's a very fulsome approach. It's a very holistic approach. What I'd like to add is that just to taking a moment to kind of think about this a little bit. Sometimes I lose my train of thought, but that's me. Is an understanding about, palliative care really fundamentally is a right in our healthcare. How do we make sure that we meet the needs of everyone? We're not ever going to be able to, we can't make 100% of people 100% happy 100% of the time, but it doesn't mean we don't try. And I think with what we have to our avail today, we could be doing a much better job. So I think there's kind of 2 or 3 things that are going to be paramount in how we reimagine healthcare in this country, because we have to. We don't have any other choice, because what we're doing clearly hasn't been working and is not to the benefit. So you mentioned the low wages. So you've part of the problem with the long-term care homes is you have multiple PSWs working in multiple homes because they could only get a few hours at this one, a few hours at that one. They're paid casual. There's no benefits. Predominantly they're women. I'm just going to come out and say that predominantly they're women. Quite often. I don't have the statistics in front of me, so maybe I shouldn't even say, but a lot of them tends to be a trend that they're immigrant women, and they tend to fall into this trap of these low paid positions. It must change, but we have to reimagine how we approach healthcare in this country. Otherwise, it's not going to be sustainable. I think one of the other factors that's going to be really important in this mix is compassionate companies. So that's another program that we are trying to spur is for companies, they have to go through a vetting process to ensure that their human resources policies are in alignment to support individuals who may have to take some extended time off to help care for someone at home and help take some of that pressure off. That's starting to shift, and organizations and companies are realizing that when they invest in their people and respect that life happens, we're human beings first, we're professionals second, and that we need those supports in place in order to find a good balance to take care of one another. It's kind of like that quote from Tommy Douglas. It's about how we care for each other and not necessarily how we care for ourselves is really going to show the true test of time. And just to kind of wrap up my thought on that is, there is this shift, and when you actually make sure you take care of the needs of caregivers, you provide adequate resources and compensation for those who are working in the field, it's not until we really take a different approach and have these incredibly important conversations about how can we do better and how can we mitigate the risk of falling flat when it comes to addressing the fact that we have an aging population, because I dare say we're ill-equipped. And that's one thing that COVID hasn't necessarily shone a light on it. It's just, the lighting's gotten brighter. We've known that we have to do better, but we haven't been taking action.
Someone wanted to know if a personal support worker, if they're medically trained. I think they're medically trained in basics, but they're not a medically trained that they can't give you or prescribe you any kind of medication, but they can help you to take them and, make sure you're dressed, you're washed, you're fed. And someone else wanted to know, how can we make sure that we have the same PSW come and visit them rather than the different folks? And unfortunately, as Laurel had mentioned, they're only 4 hours here, 4 hours there, depending on who they go through as their provider of work. And so a lot of times they don't get to determine whether they be your PSW for all your time. It's really dependent on who schedules them and whether or not they have done too many hours, because they don't want to go over those hours and then have to qualify for benefits and things. So those are all very hard to determine, just because they're all politically done through the various organizations that provide those services. We're coming to the end of our hour, so I just wanted to ask if there's anybody on this panel that had other questions for Laurel. I have to say that I've learned a lot today and I really appreciate it. And someone had said that they went to your website and they could not find the map that you mentioned. So I'm sure that you'll go back to your staff and see what's happened with that. And for all those who are interested, just know that the Canadian Pulmonary Fibrosis Foundation, for all the webinar sessions that were hosted this month, we will have all the links and the backups for it so that you can come back and listen to it again, as well as the links that will go to the various websites for it. All right. And Laurel has actually given you her email address in case you wanted to send her some questions. So I want to say thank you everyone for joining us today, and Laurel for your presentation. And as we move forward, I know that there's going to be many more other recordings coming up from Saskatchewan and from Alberta on their palliative care system, how it works in those provinces. So thank you everyone. Have a great day.
Bye. Be safe. Be well.